and was still experiencing frequent seizures. So approximately 1 to 2 per week. Okay. So our plasma phenytoin concentration over this period was in the range about 8.8 to 10.1 milligram per liter. But the expected target range, the word target range, 10 to 20 milligram per liter. So with the dose 200 milligram per day, so the range is reaching 8.8 to 10.1. But still she is experiencing frequent convulsions or seizures, at least 1 to 2 episodes in 1 week. So here the clinical benefit, it is not attained up to the mark because of taking 200 mg per day every day without missing any dose. Still she has experiencing the frequent seizures. Okay, here, but they have mentioned target range that is about 10 to 20 milligram per liter. Here, neurologists think like that, or a practitioner or a clinician is just reaching the target range about 10.1. So after that, they increased the dose phenytoin from 200 milligram to 300 milligram per day. So another 100 mg they increased. With this recommended dose, okay, this phenytoin saturated the patient capacity to metabolize that drug. Okay, in that dose, they measured plasma concentration of phenytoin and it was about 30.3 milligram per liter. So it is almost all 10 milligram above the target range. Yes, in this dose, the the patient, free from seizures. There is no episode of seizures, okay, and she is totally free, but she is suffering from important, okay, side effect that is called ataxia. The patient experiences and she is severely ataxic, not able to walk, and there is difficulty in the initiation of the movement. So this is one of the side effect. So the patient was fit free but severely ataxic. So dose is reduced to 250 milligram per liter because of that side effect. But in this 250 mg, the plasma concentration they measured, it is about 14 milligram per liter. So it is in the target range between 10 to 20. But fits recurred, but the frequency of occurrence of seizures is decreased. Okay, but not in 1 to 2 episodes in a week, but at least 1 or 2 in a month like that. So still it is troubled by the seizures by this patient. In this way, okay, the broad population target range, they have given 10 to 20 milligram per liter for phenytoin. But here with the dose 250, the plasma concentration 14 milligram per liter, but still the patient experience seizures, there is a decrease in frequency. So this is not optimal. So there is no maximum clinical benefit by this dose. Okay, then they increased dose by another 25, so total 275 milligram per day. And there, the plasma concentration measured in 1 month apart, it is about 19.7, another time 17.7 milligram per liter. Almost all reaches the peak level of target range that is near to 20 milligram per liter. In this dose, the patient is seizures free for next 2 years. Totally, there is no seizures at all, and there is no toxicity like ataxia and some other side effects related to this dose about phenytoin. Okay, so now optimum phenytoin concentration in this patient as confined to the upper reaches of the population target range. Even the concentration is about 40 milligram per liter, still the patient experiences, but frequency is decreased. But the dose 275 milligram per day, there is no seizures at all in the next 2 years and no any side effects. So why I'm giving this scenario is because this case is related to today's topic called therapeutic drug monitoring and target concentration intervention. So why it is required? Because this is the classical case. So many patients will we have seen in daily practice seizures and all, but the dose adjustment according to the clinical response by the patient and without any symptoms, because without any side effects, because the patient will take 2 to 3 days, and after that the patient himself stop the taking of medication because of trouble. It is nothing but adverse effects or side effect caused by the drug. They will say, I am totally all right. I have the fever, cough, etc. But after taking this tablet, I am experiencing severe generalized weakness, not able to walk, or sometimes rash, etc. So this scenario gives guidance to us like, so we have to adjust the dose according to the clinical response in the patient. How to adjust? One is by asking the improvement, like whether your symptoms are reduced totally. Along with that, are you still experiencing any term side effects like this? So based on the measurement of plasma concentration of a drug, or that is concentration of the drug either in the plasma or in the blood, it gives guidance to the clinicians to adjust the dose. What is the purpose? To get maximum clinical benefit and without any trouble to the patient. So with this scenario, we will come to our topic is, that is therapeutic drug monitoring and target concentration intervention. So the presentation outline of today's webinar is like introduction, definition of TDM, goals, objectives, what is the criteria, and what are the indications. Because we will not measure the drug concentration in every patient, and is not possible at all. So what is the indication, and what are the factors affecting this process called TDM, and what is the process, and what are the analytical methods we use to measure the concentration of a drug in the plasma or in the blood, and what is the time of collecting the sample. That is very important, because based on that it gives, because the time is very important, and from where, whether we'll use whole blood or serum, that is also very important. Clinical interpretation, and what are the common drugs requiring this therapeutic drug monitoring. After measuring this plasma concentration, how it is useful clinically. You have seen one case scenario, complex partial epilepsy or seizures. There, they adjusted the dose according to the response of the patient. And what are the problems we will face during this process, and what are the limitations? After that, the recently uh, evaluating subject called target concentration intervention. Related to that, what are the objectives, principles of target dosing, target concentration strategy, and what are the differences between target concentration intervention and therapeutic drug monitoring. So this is the outline. We'll talk one by one, okay, as much as possible in the next 1.5 hours. So, what is TDM? You already know that it is a therapeutic drug monitoring. So, measurement of drug concentration where in the blood or in the plasma. Why? Which facilitates adjustment of dose of a drug. Why we need, why we have to adjust the dose of a drug to get the desired clinical effect or pharmacological effect, because the patient taking the drug for 1 month, but there is no response. So then what is the necessary of taking the drug since 1 month? 1 month. So because we have to measure the drug concentration, whether it reaches the therapeutic range, whether it is in the range or below that. If it is below, there is a suboptimal response and there is no improvement in the patient symptom. That's why there is a there we have to measure the drug concentration. So apart from that, it can guide the clinician, okay, to adjust the dose for the benefit of the patient, and it provide effective and safe drug therapy in the patient. Okay, so here serum concentration of a drug is necessary, okay, to which helps to guide the clinician. Why should drug level be monitored? Why we have to monitor? Because some drugs have narrow therapeutic range. Okay, because you know the lithium, it is a mood stabilizer used to treat for mania and as well as for prophylaxis of mania. But it is ranges from zero point 0.5 to zero point 0.8 milliequivalents per liter, because very narrow range. Below zero point 0.5 there is no effect at all, and above zero point 0.8 approximately 1 or 1.5 milliequivalents per liter, the patient experiences severe side effects like tremor, even hypothyroidism, goiter, okay, etc. So because of these, the patient is stop taking the drug. Okay, so we have to maintain the drug level in the range like zero point 0.5 to zero point 0.8. So that's why in the concentration above upper limit it can be toxic, and below the lower limit the drug can be ineffective, like they doesn't produces proper response in the patient. So and remember, not all the patients have same response at similar doses. It could be inter-individual variability. So that is the term called pharmacogenetics, because of the genetic constitution in one patient is different from another patient, but they are suffering from same disease and they are taking the same drug with the same dose, but response is different. So monitoring of drug therapy, yes, it can be done by using measuring the therapeutic outcome, that is called clinical endpoints. Okay, what is the clinical endpoints? Suppose when you are giving AC inhibitors for hypertensive patient, so the BP is about 170 by 120 millimeter of mercury. So first time you are diagnosed and you have given some AC inhibitors. After that, after 20 days, after follow-up of the patient, we'll measure the blood pressure of that patient. In that condition, the BP is decreases from 170 by 120 to 130 by 90 or 80. So this is clinical endpoint. We can measure the antihypertensive drug efficacy by measuring the blood pressure. That is clinical endpoint. Pharmacodynamic measure. Yes, here suppose the patient is taking lithium for manic, you have treated, and for the prophylaxis you prescribed lithium like 600 milligram per day. In that condition, when you assess after 1 month with these condition like mania, you are not able to come to conclusion like, yes, the dose of this lithium 600 mg every day, it is totally resolving all the symptoms of mania in this patient, because there we are not able to measure the important, that is symptom scale. So here we have to measure the plasma concentration of the drug called lithium, that is act as a surrogate marker, where in case we go for measuring pharmacodynamics of the drug. Next, pharmacokinetic measures. Yeah, it includes absorption, distribution, metabolism, and elimination process. There, we will include this called therapeutic drug monitoring. By using this process therapeutic drug monitoring, we will measure the drug concentration, because by using the principle of pharmacokinetic, we know the important thing, that is concentration of drug in the plasma. So by this way, we can monitor the drug therapy. One is therapeutic outcome measures and pharmacokinetic measures. Is the pharmacological effect being translated into therapeutic effect? Yes. In case of anticonvulsant drug therapy, we are giving broad spectrum antiepileptic like carbamazepine, valproate, lamotrigine. There, we can assess the seizure frequency. Suppose the patient, after taking this phenytoin, the seizure frequency like this, and after administration of the newer drugs like levetiracetam, the seizure frequency is very low like that. And drugs for angina, when we give these beta blockers, calcium channel blockers, etc., even sublingual nitroglycerin, the frequency of attack of chest pain, that is also reduced. And diuretics we can use in the treatment of edema of any etiology. There also we can measure the, what is that, clinically the swelling in the lower limbs after administration of diuretics. So here pharmacological effect being translated into therapeutic effect. Yes. So next is the drug producing the required pharmacological effect. I already told surrogate marker, it is the endpoint that is measured in place of the true endpoint, and that relates in some way to the endpoint of primary interest. Okay, that is concentration of the drug in the plasma. It acts as a surrogate marker in case of we are measuring pharmacodynamics of a drug. So that is very important. And here, cheaper, easier to measure than true endpoint, and it can be measured more quickly. So that is drug producing the required pharmacological effect. So we can assess by using measuring the plasma concentration. So what are these pharmacodynamic measures? One is surrogate marker. Hello? Clinical or laboratory measurements, like after giving the drug, what is that, aspirin, we can measure the bleeding time. And after giving, that is called warfarin, oral anticoagulant, we can measure prothrombin time. Okay. And even in case of, okay, heparin, activated partial thromboplastin time, INR, that is laboratory measurement. And after giving antihypertensive drug, will measure the blood pressure, and even insulin and oral antidiabetic will measure the blood glucose level. So overall, by measuring the plasma concentration, we can measure the pharmacodynamics of the drug, clinical, blood pressure, and blood glucose. And in case of warfarin, that is INR, international normalized ratio. So based on this value, we can assess the clinical benefit as well as the toxicity associated with these drugs. So is the drug getting to the site of action? Yes, by pharmacokinetic measure. When you administer some drugs, after absorption, it will distributed in all parts of the body, and their metabolism takes place. And after metabolism, the fraction of, or the some percentage of drug which reaches the site of action. Your site of action is nothing but receptor site. Okay, for example, you are giving some drugs like SSRI drugs, serotonin, selective serotonin reuptake inhibitors. They will go and bind to the specific 581A, 1B, like these receptors in the particular site. They will go and they will act on that, they will stimulate that, and they will increases the serotonin level and helpful in reducing the symptoms in case of major depressive disorder and some other condition associated with that. So their measurement of drug concentration in the blood, or serum. Suppose the patient is taking these anti-epileptic drugs, antidepressant, antipsychotic, lithium, but if there is no response means then we can measure the drug concentration, whether in the blood or serum. So that is called therapeutic drug monitoring. So it is nothing but adjustment of dose of a drug according to its plasma concentration. Okay, it will helpful to provide effective drug therapy for the patient with minimal or absent toxic effects. That is the main purpose or goal or objective of this called therapeutic drug monitoring. So now coming to the important proper definition of therapeutic drug monitoring, it is a clinical laboratory measurement of chemical parameter that with appropriate medical interpretation will directly influence the drug prescribing procedure, and combining how it will helpful means what are the factors we will utilize for using prescribing procedure of this drug. One is combining knowledge of pharmaceutics, pharmacokinetics, and pharmacodynamics. With the knowledge of these three, will directly influencing the drug prescribing procedure. So clinical or laboratory measurement that is appropriate with medical interpretation. So, what are the goals? I already told the given drug dose produces maximal therapeutic benefit, that is nothing but efficacy, minimal toxic adverse effect. Raghu, hello?
Yes.
It is coming, no?
Yeah.
Okay. So, maximal therapeutic benefit and minimal toxic adverse effect. So, the drug must have an appropriate concentration at the site of action, that is receptor that produces the benefit in terms of clinical response. Okay, that is clinical effect. That is the one of the goal of this process, therapeutic drug monitoring. So what are the objective of this? Obtaining maximum beneficial outcome, that is outcome based approach, reduces the chances of drug toxicity, and it is economic convenience to the patient because the patient is taking the drug since 1 month, 2 months, 3 months, with the wastage of all these financial burden, money, time, etc., and still the patient is not getting the proper benefit. So that is one of the loss of economy to the patient. There is a burden. So it will helpful for economic convenience to the patients. And what are the monitoring factors? We will see the disease state, patient characteristic, because some of the drugs are produces maximum response in one race, but same drug does not produces same clinical response in another race. Differences in the race also very important. And drug interaction, yes, especially in the elderly patient, they are taking multiple drugs, that is called polypharmacy. Okay, 8 to 10 tablets in a day, they are taking this medication. In that condition, one of the drug action, which is very important for the patient life, that action is reduced by other drugs because of drug-drug interaction, and it reduces the patient variability. So we have to see all this. This is patient state, patient characteristic, drug interaction, etc. So based on that, we have to adjust the dose, okay, and it is possible, and it prevents drug accumulation. So effective means of individualization of dosing of drug is very important, and that is called evidence-based as well as personalized medicine. So, what are the sources of variability in drug response? Yes, the patient is taking same drug, that is right patient, right dose, right drug, and right time. Still, there is no drug response. What are the main factors? There is a larger inter-individual variation which affect the dose as well as response. In that condition, we will go for individualization of drug dosage. Okay, where there is a large inter-individual variation, the individualization of drug dosage is very difficult. So what are the factors? At the level of prescribed dosing regimen, you have prescribed the drug dose, proper drug for proper patient, that is rational prescription you are following, right drug, right patient, right dose, regimen, right time of frequency, but there is a pharmacokinetic variability here. One is compliance, it is nothing but adherence, concordance, older terms, because the patient is not able to follow the patient behavior to the prescribed medication. The patient is not able to follow the proper guidance given by the clinicians. You have to take this drug for 1 month, 2 months, like that. So compliance is also matter. Dosing or any medication errors. Suppose the dose is, if the dose is inappropriate, or any errors in the medication, or tissue and body fluid volume, drug interactions, these are the pharmacokinetic variability. They affect the absorption, distribution, and metabolism, and there is an improper drug response. Next is drug at the site of action or blood concentration, but there is no proper clinical effect. What are the factors which causes from the pharmacodynamic aspect? Because of drug receptor status. So the affinity of the receptor, that is drug towards the receptor, that is also very important. Any alteration in the receptor, genetic factors, that is very, very important. Suppose succinylcholine, it is given to some community people, which is metabolized by some enzyme. But in case of deficiency of atypical pseudocholinesterases, this succinylcholine is not metabolized, accumulated in the body, and produces succinylcholine-induced apnea. So because of variation in the genetic factor, and you are treating the malarial, the patient suffering from malaria, and you are giving chloroquine, primaquine, instead of that, bleeding occurs. Why? There is a deficiency of glucose 6-phosphate dehydrogenase deficiency. So we don't know because the measurement of or assessing the glucose 6-phosphate dehydrogenase deficiency in all malarial patient means the patient suffering from all there is malaria, it is not able to detect. Okay, it is very uncommon, and it is also there is no proper facilities available to detect. If you give this chloroquine, primaquine, instead of decreasing the symptoms of this malaria, there is a hemolysis because of this enzyme deficiency. And same like halothane, we are given to the patient as an inhalation anesthetic, and it produces malignant hyperthermia because of defect in the ryanodine receptors, and RAS, excessive release of calcium, and which produces muscle rigidity, fever, etc. Tolerance. This is the one of the important factor which causes decrease in the response. So the person is taking what is that, clonazepam or lorazepam for chronic insomnia, and because these benzodiazepine have higher potential to produce tolerance. So initially the patient is taking 0.5 mg clonazepam for chronic insomnia. He is getting the sleep in the first 15 days. After that, he is taking the same dose at same time. Because of tolerance, the person is not able to get the proper sleep like previous in the initial day of therapy, because requirement of higher doses of a drug to produce the given or same clinical response. That is also one of the pharmacodynamic variability. And drug interaction. Yes, it is very common. Suppose the patient is taking theophylline for bronchial asthma, and he is suffering from some enteric fever. If you prescribe ciprofloxacin for that patient, taking theophylline or theoastaline, it is commonly available brand. So salbutamol and or any theophylline drug. So there, the interaction between theophylline and ciprofloxacin, and this it will increases the toxicity, because ciprofloxacin increases the theophylline toxicity. So This is one of the example of drug-drug interaction. Totally pharmacokinetic as well as pharmacodynamic variability are also responsible for different in the drug response or failure in getting maximum clinical effects. Next, pharmacokinetic variability, dose and plasma concentration, and pharmacodynamic variability, drug concentration at the receptor level and response. So there are two differences mainly, dose and plasma concentration. But what is the percentage of drug which reaches the receptor level? Based on that, what is the response? That is comes under pharmacodynamic variability. So for this, there is a need of therapeutic drug monitoring, which reduces in the variability in pharmacokinetic phase and adjusting the dose to get maximum clinical benefit with minimal toxicity. So what are the pharmacokinetic variables? First one related to absorption, that is called bioavailability. So absorption of a drug, it affected by pharmaceutical characteristics based on the manufacture, size of the particle, shape, etc. Route of administration. So it is maximum in case of intravenous route, and it is variable in oral route, and state of the gastrointestinal tract because of diseases in the gastrointestinal tract, inflammatory bowel disease or any other, it will affect the absorption of the drug. Gastric emptying, yes, if the gastric emptying is more, so rapid escape, it means rapid metabolism or rapid escape of the drug and degradation doesn't take place. And even motility, food and other substances, that is also one of the important which affect the absorption of drug. So, like tetracyclines, we should not give these drugs along with other milk and milk products. That is because they contain calcium and produce a chelate complex. Drug-drug interaction. State of circulation is also very, very important because when there is a proper hepatic blood flow, so there is a metabolism, proper metabolism occurs. When there is an increased or decreased, it will also affect the metabolism. And finally, availability is affected. Plasma protein binding. This is very important. So the drugs, they are highly bound, means they are highly plasma protein binding drugs. They are restricted to the vascular compartment, means in the blood vessels. So the drugs which have very low volume of distribution, they are restricted to the vascular compartment within the blood vessels. Okay. So there is a high degree of binding and long acting. So the drugs with highly bound to this plasma protein, whether it is albumin or glycoprotein, so there is a long acting. It will make the drug act for a longer time. So here plasma concentration in case of this free and bound form. Suppose in case of hypoalbuminemia, because of decrease in the protein level in our body due to any reason, so there is a reduced binding of the drug to the plasma. So high concentration of free drug, it is available in the blood or plasma that produces toxicity. Okay, like phenytoin, furosemide in case of hypoalbuminemia. So more amount of phenytoin and furosemide, they are available in the free form, okay, in the blood, and it produces toxicity. In case of pregnancy, and I already told inflammatory bowel diseases or anything, there is increased alpha 1 acid glycoprotein and increased binding. So the drugs with low volume of distribution are restricted to the vascular compartment. The drugs with high volume of distribution, they are sequestered in all the parts of the tissues. So volume of distribution, it is also one of the important factor which affecting the, which comes under pharmacokinetic variable. It will affect the therapeutic drug monitoring or drug response. So it is very varies widely degree of binding to the receptors like plasma and tissue proteins, and partition coefficient in fat, abnormal fluid accumulation, and the drugs extensively bound to the plasma proteins like diclofenac and warfarin. They are low volume of distribution. And some of the drugs, you already know that the anti-malarial drug called chloroquine, it has high volume of distribution like 1300 liters per kg. Like also along with that is called digoxin. With high volume of distribution, they are sequestered in all other tissues. When there is a poisoning occurs, it is very difficult to remove the drug from the tissues. If there is a low volume of distribution, they are restricted only to the vascular compartment. Suppose any poisoning occurs, we will go for dialysis. Okay, easy to remove the excessive toxic metabolites from the plasma. Okay, so clearance next is, so that is abnormal clearance, where because the patient undergoes excretion or elimination through kidney and mainly, okay, so any impairment of the kidney means the kidney is not functioning properly, the clearance of the drug is affected. Obviously it is accumulated and it produces toxicity. Liver, yes, any diseases in the liver, because liver is the major organ for metabolism of all the drugs. Suppose if it is any pathology in this, so obviously the metabolism is there is a derangement in the metabolism and it produces toxicity. So even in the heart, they produces all these, and these are the important vital organs responsible for clearance of the drug. So where there is an impairment of all these vital organs, there is an abnormal clearance and produces toxicity in spite of good clinical response. So that is about pharmacokinetic variables, absorption, volume of distribution, and even elimination process. Coming to the pharmacodynamic variables, that is how much amount of drug that reaches the receptor. At the level of receptor, what is the concentration of drug? Based on that, there is a clinical response. So first one, genetic polymorphism. Okay, that is inter-individual variability in the drug response due to defect or overexpression of the gene that is responsible for genetic polymorphism. So in case of atypical pseudocholinesterase enzyme, there is a apnea. Polymorphism of NAT2 gene, N-acetyl transferase 2 gene, it produces two status of acetylation. One is rapid acetylation and slow acetylator. Why it is very important? Because some of the drugs, very important drugs, undergoes acetylation process like sulfonamides, hydralazine, isoniazid, and procainamide. Suppose the patient is suffering from tuberculosis, you are prescribing isoniazid, total duration 6 months, first 2 months intensive phase and another 4 months continuation phase. So we have to give this drug isoniazid throughout the duration of 6 months for the treatment of tuberculosis. Every day, decent guidelines, daily regimen of isoniazid. In the suppose the patient has slow acetylator status, this isoniazid undergoes very slow metabolism and it produces peripheral neuropathy. And in case of rapid acetylator status, it undergoes rapid metabolism. And another one is clinical benefit is decreases and it produces hepatotoxicity. That's why we have to know the genetic variability in the patient. So that is the one of the important example, and I already discussed malignant hyperthermia and some of the condition like acute intermittent porphyria. It is precipitated by giving the drugs called barbiturates, because the enzyme responsible for metabolism of barbiturates, it is absent in the patient suffering from acute intermittent porphyria (AIP). In this condition is precipitated by those barbiturate drugs. And one of the important another aspect is enzyme inhibitors and inducers. Yes. So I already told the patient is taking ciprofloxacin with theophylline. So enzyme inhibitor, this ciprofloxacin inhibit the metabolism of theophylline and theophylline toxicity is increases. Why I am addressing this drug theophylline? Because it is a one of the drug comes under narrow therapeutic range or low therapeutic index. Safety margin is very less. So when the patient is taking theophylline for asthma, when you give these drugs like omeprazole, erythromycin, ketoconazole, ciprofloxacin, there is an interaction and they inhibit the metabolism and produces toxicity. That's why when we are prescribing as a clinical practitioner or a clinician, we have to take the proper drug history. It will avoid the drug-drug interaction and it will also prevent the toxicity in the patient. Enzyme inducers, yes, all anticonvulsant drugs are enzyme inducers. We have to take special care in the when we are treating the patient suffering from convulsions and he is taking the drug anticonvulsant. Rifampicin, phenobarbital, griseofulvin. These are enzyme inducers. The classical example, you know this when you are giving this rifampicin, the patient tuberculosis suffering from rifampicin. When you give this antiretroviral drug, rifampicin, it induces the metabolism and it will effective, which will decrease the effective of antiretroviral drugs, which are used for the treatment of HIV infection. So that is the one of the important concept about enzyme inhibitors and enzyme inducers, because one of the another important factor which causes this decrease in the clinical response or increase the toxicity is drug-drug interaction. Yes, I already explained drug-drug interactions. And yes, concomitant medication. And you're not only take the history like you're taking any other allopathic medications. So sometimes the person is he will go for other alternative therapy like Ayurvedic, Unani, okay, and naturopathy, etc. Some of the Ayurvedic medicine like Shanku Pushpi, that is the one of the uh, drug which is obtained from the plant. So when there is seizure or a frequency that is convulsions, it is metabolized by the drug called phenytoin. In that condition, the suppose the patient taking this Ayurvedic product, so it is called that is a drug-drug interaction, and there is a causes loss of seizure control in that because of variation or drug-drug interaction between this phenytoin allopathic as well as the other alternative system of medicine. And drug on tolerance, that is higher doses we need in the patients in some cases like benzodiazepine, even opiates, there is a drug tolerance is one of the important factor. So next is concept of therapeutic range or window. Therapeutic window phenomena. You already know that and you discussed about this. Some of the drugs like clonidine and tricyclic antidepressant, they have very narrow range or window and they exhibits this phenomena. That is concentration or range of the drug in the plasma where the drug has been shown to be efficacious, means maximum effect without causing toxic effect. That is one of the important. Suppose the patient is taking amitriptyline for depression, 25 mg. So the patient is very good. So still some 20% of symptoms are there, 80% is okay. When you increase from amitriptyline to 25 to 50 mg, yes, almost all 10%, another 10% is relieved. When you are increasing more than 100 milligram per day, because we will get rapid clinical benefit because the patient is responding, and when you increase the dose very high, then instead of decreasing the other symptoms of depression, it causes or it reverses the symptoms because there is a these drugs have narrow therapeutic range or window phenomena. We have to monitor these drugs within that range. Below suboptimal, above toxicity occurs. So these are the drugs they produces therapeutic window phenomena. So this is the picture. It shows the therapeutic range and window. See concentration along y-axis time on x-axis. So here you have administered the drug, onset of time, and it will go like this, and here maximum concentration, and after it will reach the maximum concentration, after that simultaneously it will follow, okay, steady state and comes down. So this is therapeutic range. See here, MEC, that is lower minimal effective concentration and maximal toxic concentration. This is the therapeutic range. The drug level within this range. Okay, and area under the curve, which explains the rate or extent of absorption of the drug. So if it is below minimal effective concentration, below this line, there is no clinical response. Above this toxic concentration, so there is a toxicity occurs. So we have to monitor the drug range between these two. So what is the criteria for therapeutic drug monitoring? Which drugs need therapeutic drug monitoring? The drugs which need therapeutic drug monitoring, like narrow therapeutic range, like anticonvulsant, benzodiazepine, antidepressant, okay, cardiac glycosides, okay, immunosuppressant, anti-cancer drugs. All these drugs, they have narrow therapeutic range. Even theophylline, they need therapeutic drug monitoring. Where there is a therapeutic effect cannot be readily assessed. I already told with respect to lithium, and even case of anti-convalescent therapy or even antidepressant, because it is very difficulty to measure readily or easily with these drugs, based on the drugs and also the symptoms, because sometimes the patient won't tell proper history, means for after 1 month I am taking only this have reduced. There is no proper history given by the patient. But there is therapeutic effect cannot be readily measurable, and larger inter-individual variability in the plasma concentration because of genetic or some variation, and drugs following non-linear kinetics, like zero order kinetics, like warfarin and phenytoin, tolbutamide, theophylline. These are the important drugs. They undergoes saturation kinetics, that is zero order kinetics, and life-threatening conditions. Okay, there you are giving some drugs. Definitely, we have to measure the plasma concentration, because there is a life-threatening conditions. We have to measure the plasma concentration, and you have to maintain the plasma concentration within that limit. Okay, that is very important. That is especially in case of congestive cardiac failure, the patient receiving digoxin. That is very small amount of dose of this digoxin we are giving in case of CCF. That is very important, and which do not need TDM. Yes, definitely there is a wide therapeutic range. That is, therapeutic index is more, safety margin is very high. Then there is no need. Paracetamol, suppose instead of giving 1 to 2 gram, if you give 5 gram also, 5 gram per day, nothing will happen other than gastritis or some nausea vomiting. There, no need of therapeutic drug monitoring. Hit and run drugs, because the rate of elimination, so some of the drugs, they will stay back in the body even after their elimination. There we there is it is the TDM is not necessary, and even if you apply, we can't measure the appropriate plasma concentration, because the drug is almost all eliminated, but still plasma concentration is there. And pharmacologically, so can be clinically pharmacological, that is, it can be clinically monitored the effect, like antihypertensive drug or diabetic. We can measure the blood glucose level. According to that level, we will adjust. So in case of diabetic, we won't measure the plasma concentration of metformin or what is that, saroglitazar or dapagliflozin or any other drug. We will check the blood sugar level, and based on that, we will adjust the dose. Suppose the patient taking metformin plain, still it is 250 or 260 milligram per deciliter. We'll go for adding one group, another group like sulfonylureas. So we'll give 1 milligram of sulfonylurea, any glimepiride, and metformin 500 mg once daily, two daily. One again we will follow for after 20 days. If it is comes under below 200, like 140, 150, 180 milligram per deciliter, then yes, this is the appropriate drug for this patient. So there is no need of measuring the concentration of these metformin or glimepiride in the patient blood or plasma, or where there is a less complicated or non-life-threatening disease. So there is no need of therapeutic drug monitoring and linear kinetics. That is also very important. So the drugs which follows first order kinetics, no need to measure. Yes. Now TDM process. Decision to request. Yes. What is the process? Any toxicity? Yes. The patient, after like giving some phenytoin, there the person developed hyperglycemia or anything, or bone marrow, this one complications, or any gum hypertrophy, okay, and even seizure. So one is toxicity. Obviously, the patient developed toxicity due to any drug, even carbamazepine you are given, it produces hyponatremia. After taking carbamazepine, the patient experiences severe, what is that, easy fatigability because of decrease in the sodium level. Okay, so the patient will tell after taking this drug only, I am experiencing this type of side effect or this one. Definitely, there is one of the indication. Lack of response, the patient will tell after taking this drug for so many, there is no, all symptoms will be there, and even that there is an increase in the symptom like lack of response. Assessment of compliance, yes, whether the patient will restrict it to the particular regimen for particular days. Yes. Assessment therapy after regimen change, that is one. Potential drug interaction and chronic administration needed, where in case of epilepsy, yes, and psychosis, and in case of mania, CCF, congestive cardiac failure, bronchial asthma, especially with theophylline, and immunosuppression, cancer therapy, we are giving anti-cancer drugs, immunosuppressive in post-transplantation patient, we are giving immunosuppressive drugs like cyclosporine, azathioprine, tacrolimus. There is a lifelong need of all these drugs. In this case, there is a TDM process. Is there is a decision for to request? Yes, we have to do the TDM. So first one, patient demographic. We have to take the patient information, age, address, occupation, reference, and indication of TDM. There is a separate form will be there for taking all these demographics, and we have to write in that sheet, including patient information age, and what is the indication. I told you the lack of response, toxicity, assessment compliance, chronic administration, yes, and precipitation factor. So any other factor which will cause derangement in the plasma concentration, etiology, other illness means concomitant medication and treatment. What was the any treatment you have taken? Past means previously and present and other. And investigation you have to check. Okay, according to that you have to go. Yes. And next is analytical methodology, means what are the methods we are using for analysis of the drug. The fundamental procedure necessary for the quantification of the drug in the body, means how much amount of drug present in the body. So recovery from body fluids, tissue, organs, or separation from the biological components. So totally that is called quantity, amount, quantification. So it distinguish compounds of similar structure because there is unchanged drug and metabolites, detect even small amount, and be simple enough to use as a routine assay, and it is unaffected by other drug administered simultaneously. Okay, so now what are the methods? Laboratory measurement, because there is a clinical or laboratory measurement of the particular parameter. Okay, one is calorimetry, UV spectrometry, fluorescence spectrometry, chromatography. That is in so many tertiary care centers and even research, they will use HPLC, that is high performance liquid chromatography, to assess the proper concentration of the drug in the plasma or in the blood. Okay, and capillary electrophoresis, these are the some of the methods They are used to measure the plasma concentration. And apart from that, immunoassay, that is radioimmunoassay, enzyme linked fluorescent polarization immunoassay, that is called FPIA, and LCMS, least count mass spectrometry. These are the some of the analytical methods they are going to use for assessing the plasma concentration of the drug. Yes. So there is a free drug monitoring, definitely, because some of the drug it is available free in the blood or in the serum, we will measure. So development of new filtration devices based on that equilibrium dialysis, ultrafiltration, and centrifugation. So it is possible to measure the free unbound drug levels in the serum. What is the advantage? Serum concentration, that is free concentration drug, is independent of changes in the plasma binding and is pharmacologically active concentration. Disadvantage? Yes, obviously, it is a time consuming, expensive, and therapeutic ranges do not exist. Sometimes, okay, even we measure the therapeutic range. Okay, with the drug level, we should not be in the therapeutic range. Expensive means we have to take lot of time. Another one is the cost of implementing all these instruments, assistant, etc. It is also a expensive, because so the patient, all the patients suffering from epilepsy, they are taking anticonvulsant. It is not possible to measure the plasma concentration of anticonvulsant in all epileptic patient. It is not totally possible because of expensive, and for one patient it will take more time. These are the drawbacks or limitation. Coming to the samples, yes, plasma or serum, it is used for drug assay. Some of the in conditions that patient is receiving like immunosuppressive cyclosporine, tacrolimus, sirolimus, there we have to use the whole blood for measuring the drug concentration, because of large shift of drugs between the red cells and plasma according with the storage and temperature changes. Yes, there will use whole blood in these three drugs, immunosuppressive. Otherwise, serum or plasma is enough. Some of the drugs, they will measure their concentration in the saliva, like phenytoin, lithium, amitriptyline, alcohol. So that's why they will use breath test for alcohol consumption. That is one of them. And urine. Some of the drug, their concentration will measure in the urine, like benzodiazepine, and even sweat, cocaine, heroin. So they will take the sweat, okay, where there is a drug addicts, because whether I have taken cocaine and heroin, because this one it is also excreted through sweat, and alcohol in, that is through breath. So these are the some of the samples we can use it to measure the drug concentration. So coming to the use of saliva, here concentration of a drug in saliva is a measure of unbound drug in the plasma. So it is a non-invasive. We can easily take the saliva. And why we are choosing lithium? Because it is actively secreted into the saliva. Okay, and drug binding to the salivary proteins, it may produce discrepancies in the plasma and salivary ratios. What is the drug? Phenytoin. So it is mainly, it will alter, because drug binding to salivary proteins, it may varies this plasma and salivary ratio. So this is not possible. And someone, they will bind to the cell debris, that is propranolol, and salivary flow may be reduced. What? Like lemon flavored sweets, the person is taken, it interfere with the salivary flow, means excessive stimulation of saliva occurs. So it will alter the antidepressant drug estimation, like amitriptyline. In that condition, we'll go for blood or plasma. Next, serum creatinine and blood urea nitrogen, means along with measuring the drug concentration from the sample, we have to measure the serum creatinine and blood urea nitrogen to check any impairment in the liver function. Sorry, hepatic, that is renal function. Okay, this is the timing of sample collection. So this is time in hours and concentration microgram per liter. When you are given the drug, yes, it will reaches the peak concentration, here maximum concentration. After that, it will comes down and which leads to very low, almost a baseline. This is called trough concentration. What is mean by trough concentration? So measuring the drug concentration, measurement of the drug concentration before giving the next dose. Okay, that is called trough concentration, and this is peak maximum concentration. These are based on the half-life of a drug as well as the dosage interval. Okay, suppose the complete elimination of the drug takes place after 4 to 5 half-lives. Okay, so suppose the patient you are taking the fifth dose or fourth dose, before giving that dose, you have to measure, that is called trough concentration. Okay, so timing of blood collection, blood sample is collected, drug concentration have attained steady state. So after 4 to 5 of life, the drug has attained steady state and may be reached earlier if a loading dose has been administered. So steady state, not it won't take 4 to 5 of life, it may reach earlier if the loading dose has given. And absorption is variable, so they're collected in elimination phase where the absorption is variable. So we have to collect the blood sample in elimination phase rather than absorption or distribution phases, and changes during the dosing interval. So that's why least variable point in dosing interval is just before the next dose is due. That is called, this is pre-dose or trough concentration. Just giving the next dose, we have to take and measure the concentration. Yeah, this one. So this is almost all one of life, two, three, four. So attained after approximately 4 to 5 of life. Time to steady state. This is independent of dosage, and this is steady state plasma concentration. Steady state concentration. So here time and concentration. So after attaining steady state, we have to take, but somewhere we have to measure, take the trough level concentration. So multiple oral doses, in example, anticonvulsant drug therapy, and should be obtained just prior to next dose at steady state condition. And peak concentration. Yeah, when in some antibiotics given intravenously, it is determined after drug absorption. For example, 2 to 4 hours after oral and zero point 0.5 to 1 hour after administration of drug through intramuscular route, subcutaneous route, etc. That is called peak concentration, which is in case of antibiotics given by intravenous. Okay, in trough concentration, will go for when the patient is taking 4 to 5 tablets or 4 to 5 times, that is multiple oral doses, even in case of epilepsy. There should be obtained, suppose the patient is taking eptoin in the morning and even one tablet, before giving the next dose of same drug, we have to take the concentrate blood sample for measuring blood concentration. So random sample, where there is a peak and trough concentration will not differ substantially, where half-life of the drug is much longer than the dosing interval. For example, phenobarbital. So there we can measure the, take the sample at any time, and we can measure the phenobarbital level, because here peak and trough concentration will not differ substantially because this half-life is longer than the dosing interval. Single sample collected at any point in the dosage interval after 4 to 5 half-life. That is called steady state concentration. So in case of digoxin, so we have to measure the plasma concentration 6 hours after administration, lithium 24 hours after last dose. So where short half-life drugs, pre-dose sampling, long half-life drugs at any point in the dosing interval, and where we have to collect one sample and where we have to collect two samples. So drugs with short half-life, their peak and trough concentration will be different. So we have to take both the samples, and the half-life is much longer than the dosing interval. So we have to take single sample. Please remember, Trough concentration and peak concentration will not differ, where the drugs with half-life is more than the dosing interval. So half-life and here peak with short half-life, drugs with short half-life, here peak concentration is varies and trough concentration totally different. We go for two samples. For assessment of drug toxicity at any time, yes, the toxicity is there. You do not wait for steady state plasma concentration or photo of life. No, at any time you can measure and adjustment of drug dose or low clearance, yes, and concentration just before the next dose. So here, where in case of drug toxicity. So what are the guidelines for sampling time? Reason for TDM you have to mention for all drugs except aminoglycosides, toxicity is peak level, failure and non-compliance, you take trough level. For aminoglycosides, you are suspecting the aminoglycoside toxicity or something, there we have to measure the peak and trough level for measuring, for checking the toxicity. For failure or non-compliance, peak level. So peak level you have to measure for checking the non-compliance of these aminoglycosides. Otherwise, for all drugs, toxicity peak level. So interpretation information is required. Patient age, weight, sex, height, smoker status, because smoking is also act as an enzyme inducer. So some of the dose which is required higher in case of the patient is smoking because it is a enzyme inducer. So you have to give additional dose. Clinical status like renal function test, cardiac, liver function test is very important because very any impairment in this function, we have to reduce the dose. Even some of these cephalosporins, their dose is reduced in renal function, impairment in the renal, except some ceftriaxone and cephalosporin because they are excreted in the that is liver through the bile. So their dose adjustment is required. Drug therapy, relevant disease status, time of sample collection, time of the last dose, regimen, and what is the indication for drug monitoring, that is lack of effect, routine monitoring, and suspected toxicity. Based on that, we have to collect the sample and we can interpret clinically. Okay. So where the serum concentration is lower than the anticipated, what are the causes for the concentration of the drug which is lower than the expected? So we want this amount of drug concentration in this patient, but there is a serum concentration is lower than the expected range. Patient non-compliance, error in dosage regimen, rapid elimination, and also when we take the sample for examination, that is incorrect time, steady state not reached, change in the hepatic blood flow, and enzyme inducer, induction of metabolizing enzymes, poor availability, and increased plasma protein binding. Here the drug acts for longer time and very low form of free drug is available and enlarged apparent volume of distribution. These are the important condition where the serum concentration is lower than the anticipated. So same like what are the factors which cause the serum concentration higher than the expected? Error in dosage regimen, increased bioavailability, and the drug is eliminated very slow manner, inhibition of metabolizing enzyme. Yes, so where there is an inhibition of metabolism, obviously there is no metabolism, the drug is accumulated and more concentration, decreased plasma protein binding, low volume of, and decreased renal function because here the renal system unable to excrete lithium, it is excreted through renal system similar like sodium. So aminoglycoside, digoxin, and decreased hepatic function, their theophylline is excreted in the liver through bile. So there is the toxicity is occur and more concentration is there at the level of receptor or in the blood than anticipated. So yes, serum concentration is correct, but patient does not respond to therapy. What are the causes? Their serum concentration is lower than the anticipated and is higher than the anticipated, but serum concentration is correct. Yes, in the within the therapeutic range. but patient does not respond clinically. Yes, this is altered receptor sensitivity because tolerance it is also one of the factor, and receptor sensitivity after chronic administration there is a alteration, so same affinity is not maintained, and drug interactions at the receptor site. Yes, some of the drugs it will occupy the receptor and there is no free space for the another drug which is required for therapy. These are the causes for serum concentration is correct, but patient does not respond to therapy. Yes, if these factors cannot be eliminated, like the drugs which follows linear kinetics, we go for new dose like the lithium. The patient is taking 600 milligram, but the level is very low and the patient still experiencing more symptoms of mania. We have to revise the dose. We can use this formula like old dose and what we require, that is desired drug concentration over old drug concentration, and we have to adjust the new dose for that particular patient for that particular condition. So what are the drugs commonly monitored? Anticonvulsant, like managing non-responders, and situation like suspected drug toxicity, dose adjustment, and target concentration selected, which would be lead to optimum seizure control. For example, yes, in the first problem only, I explained phenytoin 10 to 20 microgram per ml. There, obviously, the patient in that case 19.1 time, another point 17.1. So upper limit of the target. Valproic acid 50 to 100. Okay, so that is the range. Yes, here sampling time immediately before next dose, that is called trough level, where in case of phenytoin peak levels for confirming toxicity, that is levels should be taken phenytoin 3 to 4 hours post dose, valproate 1 to 3 hours post dose. So range 17 to 17 and valproate 40 to 120. So lithium, no need to explain once again. 12 hours after the preceding dose, first TDM done. Yes, within 48 to 72 hours means after giving within 3 days we have to measure the lithium concentration first of once you started the therapy. Subsequently done weekly for first 1 month, every month. Yeah, first month every week. Then one time in a month, then monthly for next 6 months. Okay, and after that, after 6 months, no need to measure the concentration every month, once in every 4 to 6 months. So that is a very important. So weekly and monthly and 11 in 4 to 6 months. Zero point 0.5 to zero point 0.8, more than 1.5 milliequivalent tremors and others. If it is above 2 milliequivalents per liter, severe toxicity occurs. Antidepressants at a given dose may vary in excess of 40-fold, and here genetic polymorphism, that is a metabolic enzyme responsible for this metabolism of antidepressants called CYP 450. And digoxin, yes, reason for therapeutic failure, assessing factors like renal function or drug interactions. Sample taken at least 8 hours post dose to allow for redistribution. And this is the range for digoxin, cardiac glycosides. And aminoglycosides, because of tissue accumulation, so it produces nephrotoxicity and ototoxicity. In these cases, we have to measure peak as well as trough concentration in all the patients with renal failure. And even when you are giving aminoglycosides more than a week, we have to measure the concentration. And gentamicin, the range is 4 to 10 microgram per ml. So this is also discussed. This is one of the drug with narrow therapeutic index. Sample means immediately before next dose, trough level we have to measure, and range is 5 to 20 milligram per liter. And cyclosporine, anti-tubercular drugs. So that is slow responders, drug-resistant cases, drug interactions. I told you because of rifampicin is one of the best drug, first-line drug. When you are giving other antiretroviral drug, it induces the metabolism and causes treatment failure related to HIV infection and other associated disease states. These are the important factors which causes the effective in the failure in the effective in treatment or toxicity. Antiretroviral drug. So here, better virological outcomes and few treatment discontinuation with therapeutic drug monitoring, because never been. It is one of the important drug is used, but it also produces severe toxicity from minor to even there is a toxic epidermal necrolysis or Steven Johnson syndrome. That's why we have to measure. And anti-cancer drugs, because they need long-term administration, and here therapy is essential part for patient survival, and they produce a serious side effects from alopecia, bone marrow depression, etc. So there we have to measure the plasma concentration regularly, because it is one of the life-threatening condition, and patient need chemotherapy drug every day for their survival. So what are the clinical usefulness? Yeah, definitely maximizing efficacy. So classical example, we have to give the patient free from epilepsy without troubling or without causing more side effect, because the patient should be comfortable and he has to free from the epilepsy and he has to do the work routine work daily. So for that, maximizing efficacy in case of epilepsy, in case of asthma, in case of the drug with theophylline, and avoiding toxicity like overdose, differentiating adverse effects from disease effects, and hypokalemia, altered pharmacokinetics, all these causes toxicity we have to avoid. And therapeutic failure like non-compliance, sometimes subtherapeutic dose, drug interaction, decreased bioavailability, and malabsorption. So based on the measurement of the drug and better outcome, it will shorten the duration of hospital stay, better disease control, and dose adjustment is helpful, dose guidelines and individualized dose requirement, and avoidance of unnecessary medication. Yes, because the patient is epilepsy or any condition which is controlled by valproate or phenytoin with this dose, and don't give any other new drugs. Okay, we so there is avoidance of unnecessary medication, because completely is free from seizures with this phenytoin dose and no troublesome effect or toxicity. Then you go for that. Don't add any other new drug like that. So avoidance of unnecessary medication. So it do not understand the principles, benefits, and limitations of therapeutic drug monitoring service, and inappropriate sampling times, insufficient patient history, and other necessary data. They are the important limitations of this therapeutic drug monitoring. So, scientific accuracy of drug assay, laboratory variability in reporting, validity of suggested target range, limited accessibility and infrastructure, because it needs HPLC and that is analytical methodology. And for that, there is a skilled person is required. Lack of there is a training and skills related to handling the HPLC. And last one is obviously cost. These are because of this. Okay, the TDM is not possible for in all the patients. They are taking the drugs which need therapeutic drug concentration. So from here, we'll go for another 10-15 minutes about target concentration intervention. It is a new one. So what is the difference objectives we'll discuss. So it is a science-based method that uses pharmacokinetics, that is called pharmacokinetic absorption, distribution, metabolism, and pharmacodynamics like state of receptors, involvement, etc. So both principles to identify how patients are different in terms of parameters. What are the parameters? Clearance, volume of distribution, and maximum effect and concentration at 50%. That is maximum effect at the 50% of concentration, and it gives the dose needed to reach the target. So mainly uses both principles of these pharmacodynamics and pharmacokinetics, and in terms of parameters, because these are the very important parameters which are responsible for the concentration attained at the particular site. So use the individual parameters to predict the dose required to achieve the target. Okay, like zero point 0.5 to zero point 0.8, Okay, to administer the predicted dose in order to achieve the therapeutic target, okay, and to improve the clinical outcome as well as being a cost effective use of health resources. So that is the target concentration intervention. So what is the amount of drug concentration? It will be there at the particular target. So to improve clinical outcome, that is the best because we have to improve the benefit of the patient in cost effective use of health resources. So what are the objectives? Yes, appreciate how a target concentration strategy is essential for rational clinical use of medicine. Okay, that is right dose and etc. Patient to right dose, right time of frequency and frequency of administration, and understand when and why individual patient monitoring can be used for dose individualization, and what are the difference between or how it is this target concentration intervention different from therapeutic drug monitoring. What are the main differences? So this is about objective of target concentration. The target principle of dosing. Here therapeutics, it involves two-step decision process. So we have to take the suitable medicine to treat the disease process. One, right dose of the medicine must be administered to achieve the required effect to treat the disease. For this target approach, we have to know the knowledge of pharmacokinetics, pharmacokinetics, and pharmacodynamics to predict the right dose for that right patient. Once a medicine has been chosen to achieve a desired clinical response, okay, the target effect for the patient should then be established. Okay, so that is the main important thing in target principles of dosing. So what is the choice of target effect? It balance between the therapeutic benefit and the toxicity. That is called choice of target effect. And clinical judgment, along with that clinical judgment, along with comprehensive knowledge of the properties of the medicine. Once the target effect has been decided, the prediction of the right dose can then be done rationally based on the knowledge of PK and PD. Okay, so totally a balance between therapeutic benefit of the patient and also toxicity. We have to minimize the toxicity and more clinical response. So all drug effects are linked to a concentration that is defined by pharmacodynamic model, because the receptors, they have their own role in this, and widely used is the maximum effect model. Here what is that? EMAX, that is maximum response, that is EMAX, and the concentration producing 50% of maximum effect, that is C50. So how to measure the target effect? E maximum into concentration divided by concentration producing 50% of maximum plus concentration. That is the formula to calculate the target effect. And by using the maximum effect model, it can be rearranged to predict the target concentration to achieve the target effect. So target concentration is target effect into concentration producing at 50% divided by maximum effect minus target effect. So these are the formulas. They are used to detect the target effect and target concentration. So based on this, we go for target loading dose, means target concentration into volume of distribution, and target maintenance dose rate, target concentration into clearance. You already know that there is a two dose strategy. One is loading dose and maintenance dose. So obviously you know that loading dose, it depends on the volume of distribution. Maintenance dose is obviously depends on the clearance. That is the in general pharmacology. Here you are adding target effect and target dose. So target loading dose, obviously target concentration. This is calculated by using this formula called maximum effect model. Okay. So by using this, we can easily calculate the target loading dose in case of any drug. What is the target loading dose for this patient suffering from CCF? And what is the target dose of digoxin? And what is the target dose of azathioprine, cyclosporine, etc. After this, we have to maintain the same target effect. This is target range. So what is the maintenance dose rate? That is target concentration into clearance. So based on the clearance. So here, first parameter, volume of distribution, clearance, maximum effect, they are the important parameters. They are used for target concentration intervention. So how does this work? Suppose there is no pharmacodynamic model available. They have given classical example like morphine. It is used to reduce the post-operative pain in acceptable manner, that is mild degree, without unacceptable adverse effect like morphine. There is no respiratory depression or some other side effects of this morphine. So the dose of morphine sulfate is 5 mg, is repeated every fourth hour for this severe post-operative pain. So here morphine sulfate, that is 5 mg, is only contains 75% morphine. So 5 divided by 4, almost all morphine dose is 3.75 or 76 milligram for 4 hour. Sir, per hour 0.94 milligram. So 0.94 into 4, 3.76. That is morphine 3.76 is equal to morphine sulfate 5 milligram. So this is assumes. So for 70 kg adult, the steady state volume of distribution of morphine, because we know, so volume of distribution is 350 liter. So intravenous loading dose is 350 into 0.011. So how this get? So based on this 0.94 milligram per hour. So here for 70 kg adults. So 350 into 0.011. So approximately 3.8 milligram of morphine is equal to 5.1 milligram of morphine sulfate, because morphine sulfate contains only 75% of this morphine. Okay, so this loading dose is consistent with the usual starting dose of 5 milligram morphine sulfate. So this shows how this target concentration can be worked out based on the doses that have already been worked out by trial and error method. So because we know that morphine sulfate is available 5 mg, it contains 3.7. So without any model, because of the trial and error method, how we calculate the loading dose of this morphine in this case, like for reducing post-operative pain. Approximately 3.8 milligram of morphine we have to given intravenously to reduce this pain. This is just an example, because morphine nowadays it is not used very commonly. Okay, even in case of reducing severe pain in acute MI. So therapeutic range of concentration, same. They are managed by or established by trial and error approach with the initial guidance of the acceptable range. A clinical trial can be designed to compare potential target concentration, and patients were randomized, where suppose I will see another classical example of this theophylline. So therapeutic range of concentration by trial and error approaches. So they have mentioned or designed one clinical trial to compare the potential target concentration. So they're starting the theophylline drug 10 milligram per liter and 20 milligram per liter. In randomizedly, they have given these two doses with severe airway obstruction, and clinician adjusted the dose after measuring the concentration to reach the target without producing any theophylline toxicity. But finally, they came to know 10 milligram per liter was better than 20 milligram per liter. Okay, this is produces reasonable bronchodilator effect in severe airway obstruction. So 10 milligram per liter is the sufficient. You should not go for 20 milligram per liter. This is like trial and error method. So just for checking the target concentration for starting treatment with theophylline in severe airway obstruction. So this is the three ways to dose population, because same dose for everyone. No, because the dream dosing method is used in adults, and in group same dose for similar group, because same weight, clearance, and genotype, and it is usually used for children. And individual, it is dose determined by individual response, because you are giving amlodipine for one patient, and AC inhibitor like ramipril or enalapril one patient, because enalapril, the efficacy is more in reducing the blood pressure, but the enalapril is the patient is taking, still he is having high blood pressure, but the patient is taking the amlodipine with his low efficacy in reducing blood pressure. but the blood pressure in that person is reduced after 20 days. That's why dose is determined by individual response. And even in giving the same drug amlodipine for 5 mg for two patients, one patient blood pressure is decreased, another patient is taking same dose and same time, but still he is having high blood pressure. That's why it is an individual response. So this is three ways to dose: population, group, and individual. So understanding patient variability and dose individualization, we have to know the key properties of a medicine that determine the concentration and effects, like clearance, volume of distribution, maximum effect, and concentration, maximum the concentration of the drug producing maximum effect at 50%. So this patient variability in the response can be explained by individual differences in these above properties. So some variability is predictable and some is unpredictable. What are the predictable factors? You know, there's a systemic body size. We can predict. We can calculate the weight of the patient. Disease state, we can check liver, kidney, and genotype. We can use the genetic karyotyping and all other measures. We can predict random, like between subject variability or within the subject variability. It is unpredictable and it is a random. So target concentration strategy. This is a very important algorithm which uses pharmacodynamics and pharmacokinetic principle. Choose target concentration. What is the target we have to reach? And determine the volume and clearance using weight and calculate loading dose. I already told the equation: loading dose and maintenance dose rate. That is target concentration into volume of distribution in case of loading dose, and maintenance dose target concentration into clearance. So measure the response, and if there is no proper response, revise target concentration and measure the concentration and revise volume and clearance. So go to step 3, that is the equation. Based on that, we have to achieve the target concentration. So the last slide of today's session: what are the main differences between therapeutic drug monitoring and therapeutic that is target concentration intervention? Yes. So how it is different? So therapeutic drug monitoring does not have a target. That's why the word is called therapeutic drug monitoring. It provides a range, that is called a therapeutic window. You have to maintain the range, that is that does not directly lead to a suitable dose. Okay, but in case of target concentration intervention, it has a single target. We have to reach this target only. In this target, the maximum effect can be obtained. The target can be used easily to calculate a suitable dose. But here, we does not directly lead to a suitable dose. We can go for indirect method. And here, it uses PKBD principles. TDM only provides measured concentration. Yes. So this drug the patient is taking, this amount of concentration is there in the blood. But target concentration, it uses PKBD principle to estimate the individual parameters which can be used to calculate the suitable dose, like clearance, okay, volume of distribution, maximum effect, concentration of 50. Based on that, we can calculate, yes, this is the single suitable dose for this particular patient, and provides guidance to the clinician for the next dose. But therapeutic drug monitoring does not provide guidance except to a therapeutic window, which cannot be used to calculate a suitable dose. Even I told you that is 10 to 20, but the patient, even there is a reaching 14 milligram per liter or nanogram per liter, still have there is a seizures. But after increasing the dose 17, 18, 19, that time there is no seizures. So this therapeutic drug monitoring does not provide guidance except therapeutic window, but this window is cannot be used to calculate a suitable dose. Dose adjustment are often empirical, yes, means like a trial and error method rather than based on quantitative pharmacological rationale. So here it uses the target and individual parameters such as clearance, and to recommend the clinician, you advise these suitable particular dose. That's why it is called target concentration intervention. So here, accurate dose we can calculate in case of target concentration strategy. So this is the difference between therapeutic drug monitoring and target concentration intervention. So conclusion, yes, the aim of therapeutic research. So it is effective medication against the disease without dangerous toxic action, because the dose of a drug confines with the toxicity, because the very delicate problem with the drug, it produces toxicity. It is often produces the toxicity, and clinicians routinely monitor the drug pharmacodynamics, like in case of physiological indices like measuring the lipid concentration and altering the dose of statins and fibrates and blood glucose, blood pressure, clotting test, etc. And many drugs, there is no readily available measure like these antihypertensive drugs or anticoagulants, antiplatelet drugs. And in these cases, TDM is one of the essential part of clinical management, and it is one of the useful tool which uses the standard pharmacokinetic principles combined with drug concentration. What is the necessary to monitor the safety and efficacy of the drug? Okay, so and it is one of the useful tool in effective patient care management, and it optimizing the therapy without producing any means minimal or very low toxicity, and system of quality assurance of a drug management system, and right drug is given to the right patient in the right dose, and because of this right we will get the right clinical effect. So emphasis to use therapeutic drug monitoring in the most cost effective and clinically effective manner, and important maxim is to treat the patient, not the level of the drug concentration. Yes, ultimately we are handling the human beings, that is patient. We have to treat the patient, not the level of the plasma concentration or any drug level. So thank you for your patience listening since last 1 hour, 1 hour 40 minutes. Raghu sir,
Yeah, yeah, it was very well, sir. The presentation was very well.
thank
And
you.
guys, do you have any questions? You can ask Dr. Narasimha Murthy.
Yes, Rashmi Ranjan, open question. Yes, madam.
Sir, please highlight about surrogate markers.
Yes, sir. Sir, surrogate markers related to pharmacodynamic measures, sir. So one is in case of the patient is taking anti-epileptic drugs, no sir. There we can't clinically evaluation of the epileptic patient is not possible, because they will tell randomly, because they're not maintaining the proper what is that history. They will tell yes, and even after taking those drugs, still they have experienced some amount of convulsions. So there we have to go for the plasma concentration of the individual or particular anti-epileptic drug. It acts as a surrogate marker. In case of antihypertensive drug, we will take the clinical outcome like measuring blood pressure. And in case of oral hypoglycemic drugs, sorry, that is oral anti-diabetic drugs, we will measure the blood glucose level. These are acts as a surrogate markers.
Thank you, sir.
Thank you, sir.
Next, any questions? Okay, fine. I think
Sir, if any questions you ask later also, and you mail to Dr. Raghu sir, Sabluddi Elite Educator.
we can clarify it.
Yes,
How much time does it
name,
take to get results of drug concentration?
concentration. Yes, sir. Because it is based on the type of analytical method we are using. Suppose in all the tertiary center, the HPLC is one of the important instrument. we are using this one for measuring the concentration of the drug. So the obviously I don't know exact time, but approximately it will take some within 4 to 6 hours. Okay, for the proper answer, I will get the guidance from our one of the senior faculties, those who have HPLC in their center, and I will clarify the exact time for that is what is that time interval for getting the results. What it means? What is the time they have taken to get the results? H. Yes.
What is the specification of HPLC required?
Yes, so high performance liquid chromatography. So for that, we need extra, that is what's extra references of these instruments in detail. Based on that, we can answer for these questions, sir, like specification. Because based on that, what is that? One company they will provide the type of HPLC, which is used to measure the plasma concentration. So specification exactly I don't know. This one also related to instruments will clarify that. Yes, sir. Which is the most affordable method in a medical college? Yes, in case of what is that? Most affordable in medical college because every medical college doesn't have HPLC. So in that condition, definitely HPLC is one of the these things. Otherwise, we go for I think immunoassay. It is one of the alternative method to measure. And one more question: if uncontrolled blood sugar level, someone okay, Jainab sir.
I
And
will,
one
I will, I can answer for this.
yes, you answered
Yes,
that.
Suhani, in case of uncontrolled blood glucose level, it doesn't require that drug regimen has to be optimized. There
Yes,
is no need of TDM there. We have to check the HbA1c.
Yeah,
According to that, we have to modify the drug regimen.
yes, correct, Raghu sir.
okay, sir. Thank
Yes.
you.
How accurate is calorimetry for drug estimation? Yes, sir. Definitely for analytical methods. So related to this plasma concentration, separate webinar is required, sir. Related to analytical methodology, including radioimmunoassay, enzyme assay, immunoassay, and also calorimetry, LS metry, that is least count mass spectrometry, because we need a separate webinar for that. Okay. So in that we'll discuss, sir, related to this plasma concentration, because without knowing the proper one we should not tell the proper this any answer about these instruments. So any other questions from anyone, sir? Yes, Dr. Lakshmi Narayana. Yes, sir, please, sir.
You can unmute yourself, sir.
See, the quacks, they have tried all kinds of drugs. And when we
Sir,
prescribe the selected anti-diabetic oral hypoglycemic agent, we
yes,
are
sir.
not getting desired therapeutic benefits.
Yes, sir. Yes, sir. All types
So,
of oral
pardon, sir.
anti-diabetic.
Can you
Ah,
Now,
no?
all Tom and Dick and Harry, they do prescribe all kinds of drugs. So thinking that they will reduce the sugar and they will reduce all these things and all. And ultimately they'll end up with in such a situation, whatever the drugs you give, we will not get the desired therapeutic effect. How do you account for that? And in
yes, sir.
addition to that, these people, some Ayurvedic people, they say you can cure diabetes by taking this drug. Diabetes is driven away.
Yes, sir.
Ah,
Sir, in
so how is it possible?
sir, here you are trying like all type of oral anti-diabetic drugs,
Yes.
but still there is no
Because see, initially we start with metformin. So if the
metformin.
patient do not tolerate, we'll go for sulfonylureas. In case
Okay.
if they do not get response, we'll add another drug. Like that, we will titrate and we'll try to see that the patient's blood levels are maintained.
So
Sir,
not about
So we will come across such a patients wherein they have tried almost all the drugs and there will be nothing left out for us to try,
Sir, I want to
except
interrupt.
insulin.
Yes, sir.
Even insulin also we will get the insulin resistance.
Sir, I want to interrupt. I want to answer this.
Yes.
So, especially in my practice, I have seen people with HbA1c 12%.
No, no, no.
Whereas,
I don't believe in HbA1c.
okay, their fasting and postprandial will be almost 300 to 400. What I have seen,
Ah,
those persons only. So, what I have seen is the
ah,
people they will be taking medications,
ah.
whatever they have been taken, but they won't follow even small sort of dietics.
No, no.
Yes,
See, there are educated people who have been misguided, and there are uneducated people. And in fact, uneducated people are better than these educated people. At least they have some faith in the doctor and they will follow what the instructions we give.
Yeah. These
But
people will use all sort of things. At last, they will come.
and lastly, they will blame us only after having consulted all kinds of pathis. They
yes.
will end up with the crosspathy and then they will end up with allopathy to have some
Okay,
relief.
okay.
So
That is common, sir.
actually it depends on the patient, sir. My own experience is, as I was mentioning, it was almost 300 to 400 this fasting sugars,
Hmm.
where the person on counseling they were not following proper diet and all. After
Okay.
proper counseling and all, within 3 months, it came up to 150, 160, and HbA1c reduced like anything, sir. Within 3 to 4 months, with
Now, my question
proper
here
diet,
is
with
my
proper
question
diet.
here my question here is
Yes, sir.
majority of the people are
Mhm.
the staple diet of South Indians are rice.
Mm.
It is having high glycemic index.
Yes.
Yes,
So we getting the data from the Indian population or are we comparing the data with the Western population? Westerners, their food habit is totally different, and our side, Eastern people, our food habits are totally different. And is there any Indian data to say that what is the exact level of glucose level which determines diabetes? And we have a doubt. We are measuring venous plasma blood glucose level.
yes, sir.
Is
Yes.
it not? And
Yes,
what is the
sir.
difference between arterial plasma blood glucose level?
Yes. So
Do
that is a
we say
yes,
because after having distributed the nutrition to the each
yes.
and every cell comes back to the heart, right?
Hmm.
Venous blood, the concentration of glucose in the artery, concentration of glucose in the venous blood after being distributed, which
Hmm.
one is perfect criteria to take into consideration that they are having diabetes?
Okay, sir. Actually, this is one we have to think because the what is the level of this sugar level in venous blood
No,
sample and all.
we are unnecessarily following the Westerners without
Yes, yes.
the.
And also, sir, there is no much difference between
uh,
these American guidelines for
No, no,
sugar.
no. See, we shall not compare ourselves with others. Ours is unique. Our food is totally what you call balanced. In fact, it do contains all kinds of rich food only. Indians, right?
Yes, sir. Yes,
See,
sir.
that's why during pandemic of COVID-19, we
Yes,
never had much casualties,
yes, yes. Because
right?
of I think one of the immunity provided by our Indian system of food is that is helpful in I think in the
Immunity. See,
yes, sir.
ginger we take,
Yes, sir.
mustard we
Yes.
take,
Mm,
curry leaves we take.
yes.
So
But
all
major
these things are medicinal value, having medicinal value.
yes, sir. Yes, sir.
Uh,
So I
so,
think
like, do we have any Indian standards? So, because we were the first one to give to the world, the world diabetes mellitus to the world
yes, like
five
diabetic
thousand years
capital.
back.
Yes, sir. Yes, sir. Yes, sir. Sir,
So, we have become immune. In fact, we were
yes.
not knowing our own potentials, and we are simply following Westerners.
Mm.
Sure, sir. Actually, we are planning for diabetology webinars like this. We'll
Uh-huh.
get back to
Now,
detail in
because it's a
detailed
burning
discussing
problem.
like
See,
this.
Yes,
Yes,
sir.
yes.
they're expecting
Now
by
it is
2035, our
Yeah.
India will be the capital of diabetes mellitus.
diabetic
Yeah,
capital. Yes, sir.
yeah, it's a capital,
So
sir.
we have to take
Capital.
preventive measures, precautions
Sure, sir. Sure. We are planning for the diabetology one module only, not only
No,
one
no,
webinar.
that's right. You see, talking and giving lectures will never solve the issues. See, how we can plan, how we can get the results, because TDM is therapeutic drug monitoring. Likewise, when you give the drug, you should get the desired therapeutic effect. So, what modules would you like to have in this regard? Hmm?
Yes, sir. Related to these modules, so
Hmm.
related to diabetes, sir, actually there is a some concern about only means talking this our population means especially India. So
Hmm.
separate guidelines should be there. I think some Diabetology Association of Indian Diabetologist Association they recommended some of the guidelines. But
Now, they
actually,
have recommended that blood sugar level up to 250 is normal in Indian population.
Yes, sir. But when we measure now, as you know that every patient, even we are seeing the cases at the age of 5, 6 years, and even 20 years, they are more elevated blood sugar levels, sir.
No, no.
So,
See, I'm not talking about genetic diabetes.
yes,
So,
sir.
genetic variations will occur because of the food which is being contaminated with insecticides and pesticides.
Yes,
So, they're
yes.
all responsible for the genetic mutation, and that is possible for destruction of the pancreatic cells,
Ah,
especially islets of Langerhans. So, it has been
yes,
found,
yes, sir.
right? I am not talking about that.
Sir,
See, the
I think
criteria, the
yes, sir.
criteria,
Ah,
criteria for declaring an Indian patient to be diabetic.
okay, sir. Okay. So that one we have to check, sir. Any guidelines from the new one related to in our
We
country?
should have our own standard. That's what we are. My
Ah,
Yes,
yes,
sir.
sir.
instinct
Yes,
is.
Yes,
I
sir.
understand.
We'll get back to you with the answers, sir.
Yes,
We
sir.
have to check regarding that.
Yes, sir. Yes, sir. We will we have certain some separate guidelines for our Indian population related to diabetes.
Yeah,
So it
that's
is
what. That's what is
yes, sir.
needed.
It is one of the important concern. Yes, sir. Yes, sir.
And that's what is needed. See,
Yes, sir.
we are talking so many things about targeted molecule delivery and all these things. We
Yes,
have
sir.
nanobot in cancer therapy, where
Yes, sir.
the
Yes,
drug
sir.
molecule is a nanoparticle which goes and specifically destroys the cancer cells only.
Yes, yes.
Like that. See, can we have some kind of innovative ideas for especially treating diabetes?
Yes, sir. It is required, sir.
Now, that is better, I feel, rather
Yes,
than
sir. Yes,
see, it was, see what you gave a lecture on this TDM is only
sir.
of technical aspect. Practical
Yes.
aspect, I don't think that there was any use because nobody practiced. See, I'll prescribe digoxin. Okay, I'll ask him to take 5 days in a week to skip for 2 days. I'll report me after 6 months.
Yes, sir. But sir, I have got call from Bangalore only because there some of the clinician they asked me because
Hmm.
where is the therapeutic drug monitoring?
Yeah.
Because why means they said like we need some drug concentration level for that
Ah.
you advise. But I said BMC is there. Apart from that BMC they asked me. I said St. John because it is one of the research institute in along with that medical college.
No, no,
They
no.
are
I
doing
had been there for inspecting. 1 minute, 1 minute. I had been there to St. John's Hospital also
yes
for
sir,
investigating whether they have taken up a debagotrine trial.
yes sir,
When I inquired in everything there, they are
yes
not at all. They have not at all done anything. I got a call from
yes
DCGI
sir.
to go and inspect regarding the clinical trial there.
Hmm.
You cannot expect, see, because very costly procedure,
Yes
and
sir,
every individual cannot afford to go for TDM.
yes sir, yes sir. That is the one of the limitation of this
Then,
TDM.
and moreover, it is of more medical legal importance rather than therapeutic importance.
Yes sir,
They will ultimately they will blame the patient, not the doctor or not the
yes
drug.
yes yes
So what is the see? There shall be See, your webinar was very good. It was
thank
in
you,
depth,
thank
and
you, thank
you touched on all the aspects of common drugs that is going to cause problem.
thank you
That
sir.
right? That's 100% accurate.
Yes
But
sir,
ultimately, what is the benefit you are going to gain after
yes
giving this webinar?
yes sir, yes sir.
Let it should be should reach the clinicians. Let
Yes,
it
sir.
should reach the persons who are practicing medicine.
Yes.
In that way, you have to do something.
Yes, sir. Yes, sir. Definitely, we'll take this your suggestion, sir. Based on
Mhm.
that, we will implement, sir. Yes, sir.
Will
No,
implement.
that should be done. See, instead of see whatever you copied down from the textbook, you will just say you will take your own time and utter the words, right?
Yes, sir.
So what feedback you will get? That's the
Yes, sir.
most important than what we do, what we
Yes,
preach.
yes, sir. Yes, sir. Yes. The some because the main motivation of this one, sir, it will helpful for our PGs related to pharmacology. That is the one of the motto of this. Uh,
Okay, okay. You have arranged for this webinar. How many participants you expected, and how many participants have joined this? 36.
yes, sir. I think that Dr. Raghu sir knows. He is the main
And
person
how
for
many?
this.
You can give me the statistics. You just tell me.
Raghu
So we
sir.
can talk this in personal, sir.
Uh-huh.
Around 50 plus, because other questions
Right.
are there. I can
Ah.
connect you later, sir. That would be
No problem. No problem. See, because these are the burning issues which should be
sure, sure.
attended to. Attended to.
Around 60 plus had enrolled, sir.
Uh-huh. See, what is the I mean benefit and ratio? Say for your efforts. So it is throughout India, if I am right. Even in foreign countries also it has been okay.
Fine, fine, sir. We'll
Fine, sir.
take your words and we'll apply the clinical implications regarding that, sir. It
Yeah,
would
that's
be
most
helpful for
important.
the
That's most.
clinicians also.
Definitely,
Now,
definitely, sir.
I will be
Definitely.
honored if you can implement slowly and
Yeah,
steady.
yeah. Sir, we are planning for the diabetic module, and also there and all will be implementing all these things, sir.
Now, because in the interest of community, I'm talking.
Yeah, yeah. I got it, sir. I
Yes, sir.
got
Yes.
it.
Ah, okay, thank you.
Thank you,
Thank
sir.
you.
Thanks a
Thank
lot.
you.
Thank you
Thank
for
you.
your suggestions, sir.
Thank you.
Welcome, welcome.
Thank you, sir. Thank you.
And I think there's one more question where like quality assurance in drug estimations. How accurate are lab values for the clinician to interpret?
Yes, sir. Definitely the quality assurance related to this therapeutic drug monitoring. So it is based on the time of blood sampling of time of sample, okay, you have taken and measurement. It also requires the skillful training and also the quality of the instrument. Okay, so that is also one of the factor, okay, responsible for variation in the drug concentration. These are all the what is that obstacles. So that's why correct timing of sample is very important, and also the quality, that accuracy of the instrument giving the results, that is also one of the factors, sir. So it is varies from one to one, but not, there is a big difference in the quality of assurance in estimating blood concentration. So definitely it will be helpful for some patients like those who are taking very narrow therapeutic like clonidine, lithium, and it is not possible to measure the drug concentration in all the patients receiving lithium, but at least in some patients, the after giving this drug within 1 day they developed severe tremors and all, they stopped. In those conditions, definitely it will be helpful for measuring the proper concentration, and it will helpful for proper adjustment of dose of a drug.
Okay.
Excellent webinar. Thank you, sir. Someone looking forward for more. Definitely, we'll do that, sir, for your this
Sure,
one.
sure, sir. Actually,
Thank-
we are planning for medical writing, diabetology, and
Yes,
even more yet to come, sir. We are
yes, sir.
planning
Yes, sir.
modules.
So thank you, Raghu, sir. You have to say something because if there is no questions, we will wind up this session.
Yeah, it was wonderful presentation from Dr. Narsimha.
Thank
Uh,
you.
yes, for 2 hours you occupied us. It was wonderful, and thanks a lot. And thank you for all participants for attending the webinar.
Yes, sir. Thank you, sir, and
And
thank you
you'll
for
get
the.
the you'll get the certificates within a week, participation certificates.
Yes, definitely.
Yeah,
Yes.
sure, sure. We'll be intimating medical writing and all. Will be intimating.
Yes, sir.
Yeah, we are preparing it as a module, not as a single webinar. That's why it is
Mm.
taking time.
Yes, yes.
And we are doing the animal modules also, so that it will be helpful for many of your postgraduates and even clinicians and all.
Okay. Thank you. Thank you, Raghu, sir. Thank you, all the participants.
Thank
Yes,
you all. Have a good day. Thank
yes.
you.
Thank you.
Sir, regarding slides, will be providing after some time, sir. Not immediately. It will take some time. Okay. Thank you all.